Give me 1 second. I'm going to share my screen and get our present. Oh, Kim, I think you have to give me permission to share my screen. Did you hear me, Kim?
Yeah, you should be a co-host, but let me double check.
Okay.
Just 1 second.
Lydia.
There we go. Okay, try it now.
Aha, there we go. Okay. Okay, well, welcome. As Kim introduced, we are going to talk about personality disorders, and we're going to spend most of our time talking about borderline personality disorder today. Our learning objectives today are to learn the essential characteristics of personality disorders and the key differences between them, identify at least 3 disorders that commonly co-occur with personality disorders, indicate the primary symptoms of borderline personality disorder, its general course and prognosis, and the risk factors associated with it, describe common challenges that arise when treating individuals with borderline, and ways to address or reduce the impacts of those challenges, and to learn some best practice approaches for treating BPD. So before we can really get into personality disorders, we have to figure out what a personality is. So we do have just a poll to start us out with. What is a personality? You can either scan that QR code using your phone camera, or you can type slido.com into your browser and type in that code. It's going to prompt you to enter in, just in a couple words, what a personality is. Okay, I'm seeing sense of who I am. Seems like a lot of people are typing. Okay. Characteristics that make you, you, a person's character traits, how someone identifies, what makes me, me. So very similar to the other one. Character traits, it's a big one showing up here. I see in the chat who I am. Identity, traits that don't change. Thoughts, feelings, behaviors. Seeing the word characteristics a lot here. Your style of being. It looks like we have just a couple more people typing, but the word character and characteristic is coming up a lot. So I'm going to give these last 3 people a chance to get in here. Reflection of inner self. Patterns of thinking, difficulties with relationships. Who you are character-wise. What makes a person unique. Reflection of inner self. Values and beliefs is in here as well. But it seems like our biggest one is character traits and characteristic traits, which is really similar. Okay. So seems like that's about everybody. So we seem to all kind of be on the same wavelength there with characteristic traits, character traits, what makes a person unique. I'm thinking thoughts, actions, and feelings is where a lot of these are coming from, essence. So our official definition of a personality is personality refers to the enduring characteristics and behavior that comprise a person's unique adjustment to life, including major traits, interests, drives, values, self-concept, abilities, and emotional patterns. So very similar to what a lot of you said there. So if that's a personality, what is a personality disorder? So personality disorder have symptoms that impact their personality across many environments. These are long-lasting, persistent symptoms. They involve rigid and pervasive patterns of thinking, behaviors that differ from societal and cultural norms, and behavior that is adversely affecting their functioning across their lifespan. So this isn't something that they deal with at one period of time and not at another. It is across their lifespan. And these symptoms are pervasive. So they affect a person's thoughts, emotions, relationships, and self-constraint. So thoughts are the way people notice and understand themselves. It affects their emotions. So their emotional responses, the span, strength, the suitability or kind of appropriateness to context is going to change. The lability is affected. Their ability to engage in healthy relationships is going to be impacted, and their self-constraint or impulse control is going to be severely impacted. To be diagnosed with a personality disorder, they have to experience patterns in these arenas that affect their performance across important areas. So at work and their relationships, everywhere. They cause stress and harm. They have to begin, at least by adolescence or young adulthood. They're not due to substance use or another general health condition, and they're not due to a different behavioral health disorder. So about 9% of the US adult population and about 6% of the world population meet criteria for a personality disorder. That being said, they are overrepresented in healthcare settings, so that percentage goes up significantly when we enter into healthcare. Personality disorders are classified into 3 basic clusters, and we are going to cover each of these. Cluster A is characterized by odd or eccentric behaviors. Cluster B, dramatic or emotional, and cluster C, fearful or anxious. And there is a lot of overlap between the symptoms here. So many people might have symptoms of more than one, as well as co-occurring diagnoses, which we'll talk about a little bit later. So starting off with cluster A, people with cluster A personality disorders, they might seem strange or eccentric. They might be odd or have odd beliefs, but they're not psychotic. They have some traits that are similar to those and seen in psychotic disorders, but they're not typically as severe or as long-lasting. So starting off with paranoid personality disorder, this is characterized by being very suspicious and distrustful of others, being hypervigilant, and being preoccupied with the belief that other people are out to get them, out to exploit them, lie to them, or just after them in some other sort of way. So the key difference between paranoia and paranoid personality disorder and paranoia and psychosis is the degree of paranoid ideation that is present before an episode of psychosis, and whether it continues after psychosis is in remission. And I think Kana had a note here for examples as well. You're muted.
I was worried about dogs barking, so my bad. There have been several retroactive case studies done about President Nixon, and many of them have concluded that he likely had paranoid personality disorder, particularly believing that people were trying to sabotage him politically. It became well known later that he had bugged a lot of the rooms in the White House with recording devices. He recorded all of his telephone calls. Ultimately, it was these thoughts and beliefs that led him to greenlight the raid on Watergate, which led to his resignation. But yeah, a lot of studies about his personality and his behavior have kind of pointed to him having paranoid personality.
The next one here is schizoid personality disorder. This involves a marked disinterest in interpersonal relationships, so they're just not particularly interested in connecting with other people. They might view relationships with other people as unrewarding or intrusive. and they don't have little to no interest in sexual or romantic relationships. They generally are presented as cold. Other people interpret them as cold, bland, or emotionless, and they don't communicate emotions as much. But some people with schizoid personality disorder also report feeling empty or unfulfilled despite that lack of interest in others. So
if anybody has ever taken a training from me before or has seen one that I've put together, I'm a big fan of either real people or fictional people that kind of represent a certain topic that we're talking about. So for all of the different disorders, we're going to have 3 or 4 examples. So these 4 right here, we have Robert De Niro, who was Travis Bickle in Taxi Driver, Mr. Spock from Star Trek, Elliot Alderson from the TV show Mr. Robot, which has won a lot of awards, and in particular, Benedict Cumberbatch's portrayal of Sherlock. I'm going to show my nerd side just a little bit, didn't talk about Spock, but for those of you who don't know Star Trek, Vulcans suppress their emotions in favor of logic, so they're often seen as cold and unfeeling, and it particularly comes across in life or death situations. So for anybody who has seen Wrath of Khan, what do they say at the end with Spock? The needs of the many outweigh the needs of the few or the one. So for them, it's a balance of numbers. They don't really have, it's not that they don't have emotions, they just don't let them rule their choices. So in the case of Travis Bickle, it's also thought that he had PTSD from serving in Vietnam, which might impact his particular presentation in that movie. Also, notice how all of these examples for the schizoid, which is seen as like cold and unfeeling, they're all men. I couldn't really find any female examples. So that will come up again as we go along, the gender bias.
okay, and then our last cluster A here is schizotypal personality disorder, which involves distorted thinking, odd behavior, magical thinking is a big thing. So they might interpret random events or common incidents as something that has significant meaning for themselves. A lot of people with this disorder feel discomfort with close relationships, but unlike schizoid personality disorder, they still do desire those relationships. They just have some discomfort with them. So you can almost think of schizotypal personality disorder as schizoid personality disorder, but with the addition of magical thinking and odd behavior. Also, noting again here that most people with this disorder do not go on to have a diagnosis of schizophrenia or of some other kind of psychotic disorder, because their sort of magical thinking that you might see in psychosis is not episodic, it is consistent.
I just saw somebody in the chat say, oh, Kramer. Yes, yes. Kramer from Seinfeld. We also have Luna Lovegood from Harry Potter. She is usually the most commonly cited example. She dresses a little eccentric, and she has a lot of beliefs and about superstitions and things like that. Johnny Depp's portrayal of Willy Wonka in particular is has a lot of schizotypal qualities to it. And then again, Doc Brown from Back to the Future, he was kind of the crazy dressing recluse on his street, but he was actually, you know, an inventor. That's what he was spending all of his time doing.
Okay, and then moving on to cluster B. So cluster B is characterized as dramatic, emotional, or erratic. This includes antisocial personality disorder, borderline personality disorder, histrionic and narcissistic personality disorders. And we're actually going to skip over borderline in this section. We're going to return to it and then spend the rest of our time today with it. So we're going to skip over it for now, and then we'll come back to it after we do cluster C. So starting off with antisocial. Antisocial is marked by a pattern of just indifference and disinterest in the rights of others, a lack of remorse. These people or people with this disorder rarely seek treatment on their own, and they're often required to engage by a court order. Traits of antisocial personality disorder might be beneficial sometimes, depending on background. I think Kane is going to talk a little bit more about that here in a second. But we do know that antisocial personality disorder is disproportionately diagnosed in certain populations. This is something that cannot be diagnosed before age 18, but there has to be evidence of those symptoms by age 15 to make a diagnosis. This is usually a conduct disorder or oppositional defiant disorder. And antisocial, like a lot of other personality disorders, is highly associated with trauma, which we are going to talk about a little bit on the next slide.
Here again, we have a lot of male portrayals. So we've got Sir Anthony Hopkins as Hannibal Lecter in Silence of the Lambs. We have Heath Ledger's Joker from The Dark Knight. We have the Grinch. And we have Matt Damon as Tom Ripley in The Talented Mr. Ripley, which is a book about a man who was so jealous of his friend's life that he killed him to assume his identity. Notice here that all three or four of these involve criminal behavior, which comes into play with what we're talking about next.
I stole my own pen from here today.
Can I do the video first, or
yeah, you can do that. I can't click it.
We have
Well,
just a video for you.
It came on like 1:30 and I missed it. So I was like, well, let me try and jump on anyway. So yeah.
Okay, there we go.
You can see if there's mild complex trauma, you're going to have to adapt a little bit to try to get your needs met, to try to not get hurt. And so those adaptations are actually going to become maladaptations because you're going to begin to not trust people a little bit. You're going to begin to escape a little bit. You're going to begin to have anger stuff. But take it to severe complex trauma where you're in great danger and great pain all the time. You have to go to more severe adaptations. You have to go to more severe behaviors to survive, behaviors that are outside of normal, to try to get your needs met, to try to get respect, to try to not get hurt.
If we think about behavior as informative, if we have clients that have a significant history of trauma, sometimes that can lead to the development of what seem to be antisocial or criminal type behaviors. It's interesting that a lot of studies about trauma, especially the ACEs study, which has been talked about for years now since it came out, they use samples of participants that aren't representative of our society or of the global population as a whole, but we still use this data and this information to formulate different types of interventions and to spur different types of studies. It's interesting because folks who are not white, who are from different ethnic, racial, and social backgrounds, they tend to have a higher prevalence of trauma overall. And that also comes into play when we think about criminal behavior, because a lot of those studies are completed in correctional settings where minorities are already overrepresented to begin with. We should not remove a client from their context when we witness their behavior, because what would be antisocial to us based on our experiences may just be what our client had to do to survive in their environment. Just a couple of statistics. This was taken from, if you attended the culturally competent diagnosis and treatment training that we had a few years ago. She noted that African Americans have the highest lifetime prevalence of PTSD compared to any of their other racial counterparts. At the present time, in our current world, the Latino community is experiencing a high degree of racial-based violence and trauma. So it's possible that we could see an uptick in clients of Latinx and Hispanic backgrounds that start to seek services. The Black community also comprises 40% of the homeless population, 50% of the prison population, and 45% of the children in the foster care system. So again, our studies are normed on pretty homogeneous populations, whereas the folks who struggle most with significant trauma tend to be of more diverse backgrounds. So we have to just bear in mind that sometimes the criminality that we're seeing is not necessarily cold and unfeeling and violent. It was what they had to do to survive.
Our next one is histrionic personality disorder. People with histrionic personality disorder might feel uncomfortable when they're not the center of attention. You might see like exaggerated or theatrical expressions of emotions, kind of to, again, push that attention back onto themselves.
The slides are gone.
The slides are gone? Sorry about that. Okay. Thank you for letting me know. Okay, there we go. So, histrionic personality disorder, again, they have little capacity for self-reflection and emotional control. Canada, do you want to talk about our examples here?
Absolutely. So we have Vivian Lee as Scarlett O'Hara from Gone with the Wind. We have Regina George from Mean Girls. We have Ben Stiller as Derek Zoolander. And then we have Nathan Lane as Albert Goldman from The Birdcage. Albert's character was deliberately written as somebody overly dramatic and over the top. But that's what makes that character a good example of what we're talking about. But it's also interesting to note that Vivian Lee in real life was diagnosed with bipolar disorder. And when you look for examples of histrionic personality, Scarlett O'Hara comes up, and also Vivian Lee's portrayal of her character in A Streetcar Named Desire, both of them. So I don't know if her co-occurring bipolar can be a co-occurring diagnosis, if that informed those characters or not. It's just an interesting correlation.
And our next one is narcissistic personality disorder. So this involves kind of a grandiose sense of self-importance, an inflated sense of self-importance, a preoccupation with fantasies of unlimited success, power, brilliance, talent, etc. And they hold the belief that they are superior to others. This fragile sense of self generally can be traced back to attachment trauma or childhood maltreatment. Like with many of these diagnoses, they are often caused by trauma. And you might also see traits of interpersonal exploitation and emotional lability. So the DSM tends to focus on the grandiose behavior, even in the new DSM-5 formulation, classically we focus on the grandiose presentations and miss the more vulnerable elements, which leads us to miss treatment targets. and measurement has focused on exaggerations in self-esteem. So, Kaner, did you want to jump in here?
Overall, clients with narcissistic personality have significantly higher rates of dropping out from therapy. Some estimates put that as high as 64%. And if we consider that people don't come to us when life is great, they come to us when they have problems. If narcissists think that there's nothing wrong with them and everything is wrong with the world, them seeking treatment on their own is also more unlikely to begin with. Narcissistic grandiosity is also associated with decreased use of clinical services and increased dropout in any type of clinical intervention. There is also the narcissistic shame rage spiral. Participating in therapy activates feelings of shame for people who have narcissistic personality. Narcissism and shame are linked. The feelings of insecurity, inadequacy generates the opposite behavior as a defense mechanism. So people become enraged at simple feedback because the source of who activated those feelings is sitting across from them in a therapy session. The shame is difficult to address because the person lashes out at the therapist for anytime they activate the underlying shame. Some researchers have started to believe that narcissism exists on a spectrum or a continuum, and that there are different types, such as vulnerable narcissists and grandiose narcissists and malignant narcissists. It's interesting to note that why we think that antisocial personality disorder folks might be more predisposed to violence, it's actually malignant narcissists that are the most dangerous and likely to be violent. The challenge with narcissism is that it's very different in each individual. Most of the behavior overall, though, is antagonistic. It puts people at odds with each other. Someone wants special treatment, but they're callous or indifferent and unaware of others' feelings, and they're using others for their own self-enhancement. So our examples here are Dr. House, who just happens to be a modern character based on Sherlock Holmes. For us old folks here who remember the 80s, Michael Douglas as Gordon Gekko in the movie Wall Street pretty much epitomizes the narcissist personality of the 80s. We have Meryl Streep as Miranda Priestley in The Devil Wears Prada, and we also have Audrey Hepburn as Holly Golightly in Breakfast at Tiffany's.
Okay, and then cluster B also has PPD, but as I said, we are going to return to that at the end here. So we're going to skip right to cluster C. This cluster is characterized by anxiety and fearfulness. Starting with avoidant personality disorder. So avoidant personality disorder, people with this disorder are very scared of ridicule, of being rejected, being criticized, so frightened of that they avoid socializing. But they still crave that social connection. They want to have those relationships, but they tend to believe that they are just unappealing on a basic level to others, and maybe even undeserving of those relationships. So as you might imagine, that comes with really poor self-image. They believe that they cannot interact socially for one reason or another, which causes that intense anxiety and leads them to withdraw and avoid social situations.
Our examples here, we have a couple of folks who are fictional and a couple of folks who aren't. 70s singer Donny Osmond has actually spoken out about his diagnosis of avoidant personality. We have George McFly from Back to the Future. We have Michael Jackson. And then we have Sean Connery's reclusive character in the movie Finding Forrester. Sean Connery based his character on writer J.D. Salinger, who was suspected to have avoidant personality disorder. he was very reclusive and didn't socialize, didn't take a lot of interviews with people. It's been suspected that Michael Jackson and his siblings experienced abuse from their father growing up. If you've ever seen him give a interview where he talks about his parents or his childhood, you can see a lot of discomfort and a lot of trauma being activated as he has those discussions. And it's important that we focus on 1950s George McFly, the original one, because by the end of the movie, he's not the same person as he was before Marty has influence on him. So originally, he's very socially withdrawn, he's very isolated, but by the end of the movie, having interacted with his son in the 1950s, he's much more confident and self-assured. So original George McFly was avoidant, but present day George McFly is not.
And then we have dependent personality disorder. People with dependent personality disorder have a significant need to be taken care of across environments. So this makes them really willing to endure abuse and poor treatment because they feel that they cannot be without this other person. They lack that self-confidence to do things on their own. So it can put them in some pretty dangerous situations because they feel like they cannot be apart from whoever they have kind of latched onto.
So our examples here, we have Meryl Streep and Kevin Kline from the movie Sophie's Choice. We have Kristen Stewart and Robert Pattinson from Twilight. And we have Bill Murray and Richard Dreyfuss in What About Bob? It was very difficult to find examples that weren't a woman dependent on a male partner. What About Bob was pretty much the only example that I could find that did not show that dynamic. So again, when we come to gender bias a little later, we're seeing that play out in several of these diagnostic categories.
And then our last one here before we pivot back around to borderline is obsessive compulsive personality disorder. People with OCPD are very preoccupied with order and control. That preoccupation actually extends into their interpersonal relationships as well. They might be so overly concerned with the details of a task that they are kind of not able to actually complete them. They get so caught up in the process of it. They have a very rigid adherence to rules and regulations. They might refuse to accept help from other people unless they are absolutely sure that that person is going to do the task exactly the way that they would. They tend to lack flexibility, openness, and that can make them really inefficient. They are so confident that they have found the right way to do something that they have a really hard time stepping outside of that one way of doing things.
So because there's such a fine line between obsessive compulsive disorder and obsessive compulsive personality disorder, this seems to be the most commonly diagnosed of the personality disorders. For our examples here, we have Natalie Portman in Black Swan. We have Sheldon from The Big Bang Theory. And in terms of real people, we have Steve Jobs, who was the founder of Apple. And we have Howard Hughes, who was a very famous engineer and movie producer in the 30s, who eventually became very reclusive and very obsessive with his environment over time.
Okay, and now we have reached BPD, borderline personality disorder. So in short, The symptoms are a persistent pattern of instability in relationships, self-image, and affect, being preoccupied with abandonment, real or perceived abandonment, and making sometimes even extreme efforts to avoid that. You can imagine how that would create intense and unstable relationships, impulsive behaviors, self-injurious behaviors, suicidal ideation, lability of mood, feeling lonely, empty, and having difficulty controlling anger, among other strong emotions.
So for our examples here, we have Faye Dunaway as actress Joan Crawford in the movie Mommy Dearest, which is based on the memoir by Joan Crawford's daughter, Christina, about her life growing up with her mother. We have Kathy Bates in her Oscar-winning role as Annie Wilkes, who was an obsessed fan in the movie Misery, based on the Stephen King novel. We have Michael Douglas and Glenn Close in Fatal Attraction. Glenn Close's character, Alex Forrest, seems to be written intentionally as having borderline personality disorder. And we have Winona Ryder as Susanna Kaysen in Girl Interrupted movie, which is again based on the memoir of the same name by Susanna Kaysen, who was treated for borderline personality disorder. So we kind of hinted at it a little bit as we moved along, but notice that all of these examples are women. So when it comes to the less emotive or more angry or aggressive types, as we think of them, we tend to see a lot more male representation. But when it comes to overly emotional or hysterical or vain portrayals, we see a lot more women in our media. And that goes into our next slide, which talks a little bit more about bias.
So there is a big gender bias with the way BPD is diagnosed. About 1% of the population in general is diagnosed with BPD. However, that probably doesn't accurately describe who actually has BPD. There is so much overlap between the symptoms of BPD and CPSD, bipolar disorder, etc. So it can be difficult to find like the actual number of who might meet criteria for this. 1% is not a huge chunk of the population, but they are overrepresented in healthcare settings. So in primary care, they make up about 6% of total patient population. In outpatient mental health, that number jumps to 10%. And then in psychiatric inpatient settings, it goes up to 20%. So as we've kind of been getting at, there is a gender bias. About 75% of people diagnosed with BPD are women. Although this is predominantly diagnosed in women, researchers have found that BPD symptoms occur in similar frequency between men and women. And this has been found several times. I found 3 studies from 2018, 2013, and 2017. So it's been found a couple times. This discrepancy is likely due to stereotypes about sex and gender roles. Men with features of BPD are more likely to be diagnosed with things like narcissistic personality disorder, antisocial personality disorder, PTSD, whereas women are more likely to get the diagnosis of BPD. So the etiology of borderline personality disorder can be kind of grouped into 3 basic categories here. So genetics. There is no specific gene or gene profile that's been found, but it has been found that people with close family members who have BPD are at a higher risk themselves of developing BPD. And we'll talk about some of the reasons that might be aside from genetics, but it is likely that there's a genetic component as well. For environmental factors, a list of factors were found in over 70% of individuals with BPD, and they were things like childhood maltreatment, maternal separation, poor parental attachment, inappropriate boundaries with family, and parental behavioral health conditions. So again, kind of getting back to that close family member with BPD puts you at increased risk. And they found brain functioning differences. So individuals with BPD were found to have lower performance in neurocognitive testing in attention, learning and memory, cognitive flexibility, processing speed, and visual spatial capabilities. So there are some brain function differences as well. So we're going to talk a little bit about social and psychological factors. Kana's going to jump in here.
So again, many of us have heard about the ACEs study, the Adverse Childhood Experiences study, which found that pretty much every type of abuse, physical, sexual, emotional, psychological, emotional neglect and physical neglect, particularly around food insecurity, and household issues or events. So being separated from parents, domestic violence, parents having mental illness or substance abuse, or being incarcerated, all of these things increase the likelihood that someone will be diagnosed with some form of mental health issue, including borderline personality. In addition to the ACEs, and I can only find the one study that mentions this, the Harvard, I want to say it's the Harvard Institute for the Developing Child.
Harvard Center for Developing Child.
Yeah. And the American Academy of Pediatrics did a study in 2015 that showed additional events or stressors that similar to the ACEs could increase someone's likelihood of being diagnosed with a mental health issue. So they called them CATs, compounding adverse toxic stressors, poverty, homelessness, discrimination, racism, bullying of any kind, being a refugee, so not just community violence, but people who have fled violence in their home country, and early childhood intrusive surgeries. So someone who had a medical condition that required a lot of surgeries during childhood. It's interesting that the last one is the only one that doesn't involve feelings of shame or humiliation for the person. The study that those come from, I have that in the references slide at the end. But if you've never heard of CATs before, I would suggest adding them to your list of what we go over if we do an ACEs screener. They're not included, but they all have been found to be very impactful.
As we've kind of gotten at, there's a lot of symptoms of BPD that overlap with those of other diagnoses. There's also a lot of co-occurring diagnoses that are pretty common with people with BPD. So diagnosing someone with BPD or really any personality disorder is difficult because of the high co-occurrence with other mental health conditions. So are you guys able to see my screen? Okay. So a large percentage of people with BPD experience a mood disorder at some point during their lifetime, the most common being depression and bipolar disorder. There are some differences, mainly being that these mood symptoms of MDD and bipolar tend to last longer than those with BPD, which usually last a couple hours to a few days. PTSD, in particular amongst trauma disorders, is very common for those with BPD. As we've discussed, trauma is a significant contributing factor. They actually coincide at such a high rate that some researchers think that they might not even be two actual distinct diagnoses, but instead represent a spectrum of trauma-related pathology. So also diagnoses like generalized anxiety, panic disorders, phobias are also pretty common. Dissociative disorders, similar to the relationship between PTSD and BPD, some experts view both BPD and dissociative disorders as manifestations of similar trauma-related difficulties. Because dissociation is so common, used as a coping mechanism to manage those intense emotions and to manage trauma, it's very prevalent within those with BPD as well. Eating disorders, particularly bulimia nervosa and binge eating, are very common. A 2017 study actually found that there is a 37% overlap between people diagnosed with disorder eating and BPD. So in their study, 37% of the people with disordered eating also had a diagnosis of BPD. And then the last one on the slide here, substance disorders. Alcohol and other substances are very often used as a negative coping strategy, especially to kind of cope with those intense emotions. It can be used as a numbing strategy, and about a quarter of people with BPD also meet criteria for a substance use disorder. So in this slide, I wanted to hear from you guys. What myths come to mind when you think about BPD? Or what myths have you run into in your work about people with BPD? You can put it in the chat, you can come off mute, either one would be great.
Difficult to work with. Yeah.
The myth about being manipulative. Every single human being is manipulative. We all know how to get what we want. So my preference is to use difficulty problem solving.
So yeah, you said manipulative actually at the same time as somebody in the chat did. So it seems to be a common one here.
Bad parenting, which is different than trauma.
People with BPD are violent, victim mindset, cannot have positive relationships, attention seeking, untreatable. Okay. Oh.
People with physical disabilities and personality disorders are overlooked. I would say that's likely.
People with BPD can't have healthy relationships.
Unstable.
Exhausting. Okay. So thank you guys for chiming in there. Some that we came up here with here is that one, you cannot treat BPD, which I think a couple people in there said untreatable. But if you use evidence-based treatment modalities like DBT, trauma-focused CBT, amongst others, we're going to talk about some a little bit later here. If they have a strong support system, if they have a willingness to change, a lot of people can be treated and have happy, healthy and fulfilling lives. So it is definitely treatable. That people with BPD cannot lead their own independent, fulfilling lives. With the right treatment, some people with BPD will not need to be in the mental health system forever, and they can live independently with the right coping skills, with the right support system. BPD behavior is just attention seeking and should be ignored. I heard a couple of people say attention seeking. Behaviors like self-harm, suicidal statements and gestures, impulsivity are usually due to distress. Most people aren't engaging in those actions with the thought, I want attention in their minds. And, even if they are, we should never be ignoring that, right? They're in pain, they're seeking help, and they're using the tools that they have in that moment to do so. And people with BPD do not help themselves. This is a big myth because people with BPD are much more likely than people with other personality disorders to seek treatment on their own. They're hurting, they don't want to feel that way, and they do want to get better most of the time. So approaches like DBT or dialectical behavioral therapy, which we're going to talk about just here in 1 second, can help them to learn the skills to manage emotions that they might have been unable to learn in childhood or adolescence. And with that, we are going to go ahead and get into our interventions. and Kane is going to present this section.
Before we get into this, does anybody have any questions about anything we've gone over so far? The mailman is here. He's letting me know that. So I'm a big fan of Mary Vicario. I have taken her trauma-informed care certification training, and this is something that she has in her training manual. It says every challenging behavior is a survival skill. Inside every survival skill is a resilience factor that could not be safely or directly expressed in an unsafe environment. So our goal is to uncover the resilience factor in the survival skill and help survivors learn when, where, and how to use it to obtain the life they want instead of recreating the life they came from. So I think that's kind of our goal in using interventions to treat this.
So when we talk about interventions for BPD, main thing in mind is that we want to use a trauma-informed approach. We know that people with BPD very often have a trauma background. Some guiding principles of a trauma-informed approach include safety, trustworthiness, having access to peer support, collaboration, empowerment, and being aware of cultural, historical, and gendered factors. The therapeutic relationship is very important to a trauma-informed approach. While choosing an intervention is important, the relationship between the client and the counselor is twice as effective as any of these interventions to reduce symptoms, symptom severity, and improve that client's satisfaction with treatment. Some considerations when you're choosing an intervention: you want to consider your client's symptoms, their treatment goals, the available resources in your community, and your own training and skill set. What can you do effectively with this client? So the most famous treatment for BPD is probably dialectical behavioral therapy. You've already heard me mention it. DBT was developed by Dr. Marshall Linehan, who we're going to hear from on the next page here. It teaches skills to help clients accept the problems in their lives that they can change, and then help them to change the way they see the world. The word dialectic in dialectical behavioral therapy refers to a philosophical concept that two seemingly opposing forces can be true at the same time. And as we go into this, just be aware DBT does require a certification. That's just if you want to call yourself, a DBT therapist. But a DBT informed approach can be used. You can take elements of it. So we just have a quick video from the creator of DBT, Dr. Marshall Linehan, just kind of explaining what led her to create DBT and the core components of it.
People. As it turned, I started working with highly suicidal people. As it turned out, the people met criteria for borderline personality disorder, but A, I had never heard of borderline personality disorder, and B, I didn't know what it was. Even if you told me the name, I wouldn't have known. So that was the beginning of the whole thing. I had no idea what I was doing, except that I was studying suicide. What happened was standard behavior therapy of the 1970s and early 1980 blew up. And the main reason it did is because what it requires for it to work is for a person to come in and you be able to say, okay, here's the problem and here's what we'll do to change it. And for the person to say, okay, I'll try that. But the people I was dealing with immediately said, you're saying I'm the problem. And so they were so sensitive to any invalidation or statement that they were the problem that the treatment blew up. And they would either get angry at me, hide behind a chair, storm out, quit therapy, yell and scream, cry, or say they're going to kill themselves. So it didn't take me too long to figure out this was not going to work out. So I thought, okay, we're going to switch to a more acceptance-based treatment. So I'm going to validate and be very accepting. So I tried that. That blew up also, because then the patient said, "You mean you're not going to help me? You're just going to listen to me?" Most of the patients I treat have already been through a whole lot of therapy where you talk, get listened to, and understood. The problem is talking, being listened to, and being understood doesn't necessarily make anything change. So then they got really upset with me because I wasn't helping them change. So that's when I realized that I had to pull together a major emphasis on change with a technology of acceptance. So I had a technology of change, now I need a technology of acceptance. The technology of acceptance primarily was validation. So it's behavior therapy with a huge amount of validation. So problem solving, validation are the core components of the treatment.
So I was just like a little brief intro from the creator of it. The comprehensive model of DBT includes 4 modes of treatment. Most evidence supports the comprehensive mode. However, a DBT-informed approach means that counselors are using some of the modules, but not all of them. So DBT actually uses both individual sessions and group therapy to practice and reinforce the skills being taught. So individual psychotherapy and then the skills are practiced in group settings. Phone coaching is a part of comprehensive DBT. This involves the therapist being available to clients by phone in between therapy sessions. The aim of this is to generalize the skills they're learning in therapy to their everyday lives. So the calls primarily should focus on how the client can figure out what skills to use and how to use those skills to navigate difficult everyday situations. Sometimes they also do focus on how to get through a crisis, suicidal or otherwise. So clients can call, for example, when they're feeling very, very overwhelmed, or maybe they're at risk of harming themselves, and the therapist can kind of help to coach them through that, within boundaries and limits. And then consultation teams for the therapist. The purpose of this is to provide support for the therapist. It's like therapy for the therapist, to have a group of people to talk about their cases. It gives them a chance for feedback and a chance just for, support, because it can be very stressful to work with clients with BPD. So it can give them kind of an outlet for that stress. Okay, so the kind of 4 skills for clients in DBT are mindfulness. Clients are taught how to observe sensations, describe or label the sensations, and then participate fully in the present moment while maintaining a non-judgmental stance. So this can help them to kind of get through particularly difficult moments. The stress tolerance, they learn crisis survival skills. They learn to soothe themselves in healthy ways rather than becoming completely overwhelmed by their emotions or avoiding their emotions completely. Emotion regulation, they learn how to identify and understand their emotions. By learning those skills, they can then decrease the intensity of their feelings by learning to sit with the discomfort without acting on the feeling. And this ties back to mindfulness, which can be a great way to do that. Emotion regulation skills, though, are for everyday concerns, versus the stress tolerance skills are used for crisis. So that's the differentiation there. And then lastly here, interpersonal effectiveness. These skills help clients to improve their understanding of what their needs are in a relationship and how to communicate those needs in a healthy way and kind of help to balance with other people as well. So it can kind of help them to engage in relationships in a way that is not damaging to themselves or to other people. So for one DBT intervention, we have Tend the Garden, which Kana is going to walk you through. You're muted.
A few years ago, I was at the Tri-State Trauma Network fall conference, and they had a speaker who just happened to work at border control in Texas, and he had with him the DBT for PTSD workbook, and then a companion workbook as well. And so this was one of the interventions that is from that workbook. I'm a big fan of ones that involve visual cues or visual representations. If you've ever heard Dan Siegel talk about the hand brain and flipping your lid, the fear center of your brain only thinks in feelings and pictures, and the thinking part of your brain thinks in pictures and words. So I like to think that having something that you can use a visual representation for with a client helps bridge that gap and allow them to get their thinking brain back online and assume control of their thoughts and actions. So we want to plant the right seeds. This involves taking care of your physical body. So symptoms, monitoring for changes in moods, behaviors, exercise, movement, especially of big muscle groups, helps burn off stress hormones. Eating, what are we eating? How often are we eating? Are we not eating at all? Making mindful choices about what we eat. Drugs, are we using any kind of substances? Because substances usually alter moods. And sleep, we just don't function at our best without good sleep. And so are we sleeping? What's the quality of the sleep that we're getting? And for any of these, do we need to seek feedback or assistance from a doctor or a specialist to make sure that we're functioning physically at our best? So when we pull out weeds, we're talking about those rigid, all or nothing, black or white types of thinking that can take over in a situation. Things like emotions are good or bad, they're right or wrong, there isn't any in between. Or that only weak people talk about their feelings. Difficult emotions are dangerous or destructive. If I get emotional, I'm going to lose control. Emotions are just random. They don't have any purpose. They're not related to anything. The only way to deal with emotions is just to do what I can to ignore them. We should work with clients to develop ways to challenge these thoughts and hopefully eventually eliminate them. So when we talk about checking the health of the soil, we want to evaluate the foundation of some of the beliefs that our clients hold. What are the facts of a situation? What's true? What's not true? What kind of assumptions are we making? What kind of evidence is there? Am I missing any information? What's the worst case scenario? What is the best case scenario? And then what's most likely to happen? And are they able to cope with any of those outcomes? So what is the foundation of their thoughts and beliefs that drive their actions? Pest control, that's problem solving strategies, where we work with them to define the actual problem, brainstorm solutions, and that's, no judgment. We just kind of throw out whatever we think of, and then the next step, we can eliminate unwanted or unreasonable ideas. Agree to try one solution as homework. Try to identify any obstacles and plan for them ahead of time. Have your client attempt the solution they chose. When they come back, you can debrief, evaluate the outcome. If necessary, go through the process again to try a different solution, and encourage them to ask for help implementing their solution if they need that from someone else. So fertilizers are healthy beliefs and actions. So self-compassion, self-kindness, mindfulness, and self-awareness, healthy habits and effective coping skills, building connection with others through having positive relationships, and finding purpose and meaning in life from their own emotional growth. And so when we talk about celebrate what you cultivate, this is for when your client feels like they just want to burn this garden to the ground. nothing is going right. Why do I bother doing this? They want to just chuck the whole thing out the window. We want to encourage them to act opposite. We want to look for things that have gone well. We want to look for the successes. We want to look for all of the hard work that they have done and put in, and encourage them to not see a setback as destroying everything that they've worked for so far, that it's just temporary and it's something that can be overcome and they can continue to move forward.
Yeah, and I just wanted to chime in that this is going to be provided as a handout at the end of the training as well.
Oh yes,
That's something you can take away with you. And so will this next one. Kana, did you want to intro this video?
Yeah, this is a video from Mary Vicario talking about an intervention that she calls the anger onion. And it's about the premise that anger is a secondary emotion. So what is the primary emotion? What is actually fueling someone's anger? And a colleague of hers heard about this and developed the love onion to combat the anger and the sadness and the fear that we discover from using the anger onion with a client. So making something positive from the same information.
Okay, so I will let Mary Vicario take it away here.
Welcome to Team Hope, where today we're coming together to learn strategies that allow us to have a different way of being with people, a way of being that actually promotes hope and resilience. Because our goal here at Team Hope is to just add a bit more hope, a little more resilience into the world. So today we're going to look at a tool called the anger onion. So the anger onion is a tool that came to mind as I was working with many young people over the years, and I realized that underneath their anger, there was sadness. And underneath their sadness, there was fear. And as I learned more about neuroscience, I learned that yes, in fact, in the brain, irritation equals threat or fear. I also learned that when we see anger, aggression, risk-taking, or self-injurious behavior, if we think sadness and then use it as a bridge, we can bridge from the person's sadness to their fear. And then the point is, you put in your intervention at the level of the fear. When you calm the fear, you've gotten to the root of the problem driving the anger. As I was training on this with the Columbus Care Coalition, one of their members, Jennifer McKinsey, said, "Oh, well, do you have a love onion? If you have an anger onion, you should have a love onion." And I go, "Actually, I don't have one." So she went and created one for us. So thank you, Jennifer McKinsey, for creating the love onion and allowing us to use it to peel the anger onion. And what Jennifer came up with is also spot on with neuroscience, that when we get curious, instead of judgmental about someone's anger, oh, I wonder where that's coming from. Any open-ended question engages curiosity. Curiosity engages your cortex. That's based on neuroscience, not just a pretty thought. Curiosity turns the cortex on. Thank you, Ross Green, for some of the very initial research into that. Open-ended questions engage the cortex because they engage curiosity. So if we can get curious about someone's anger, that allows us to have empathy. The empathy allows us to more clearly see, have our mirror neurons work better so we can actually feel the sadness that would be under that anger. And when we can connect with that sadness, the person feels safe enough to show us their fear. And then we can put the intervention in at the fear, at the level of the fear. Oftentimes when I work with people struggling with addiction, when their loved ones approach them and are trying to support them in their recovery, they often get very angry with those loved ones. And when we can sit down and look at that anger onion, we get curious about, oh, yes, you're having a really strong feeling about your mom or your dad's or your spouse's or someone who you really love, who really matters to you, assistance right now. They're trying to give you assistance, but it doesn't feel that way. So thanks for showing us that. I'm wondering if we can peel back the layers beneath this anger and see what else is going on. And as we do that and get curious, we often find there's a sadness that, gosh, I'm the parent. I shouldn't have my child trying to help me with this. I'm an adult. I don't need my mom telling me what to do. So there's often a feeling of being not as strong as you would like to be in the world, or feeling as if you may have let someone down. There's a sadness in that. And then under that sadness is often the fear of, wow, what if I relapse and I do let them down? And what if I can't do this? So we've gone all the way from someone trying to support you to that support feeling like another way you can fail at an expectation, which is of course not how it's meant. But when we can get to that fear, then we can say, what would feel more supportive than this? What would feel like they're with you instead of worried about you? And as we explore that, because it's different for every person, we're looking at what's really causing the anger. And now some other people who use the anger onion and the love onion will share with us some ways they use it in their world.
Hi, I'm Monica Benton, and I am a victim advocate social worker here with the Cincinnati Police Department. An example of how we've used the anger onion at our job is we are able to run some youth groups, and one particular youth group was the Youth Intervention Group through Juvenile Courts, where we met over a course of 6 weeks to help individuals who were affected by some form of violence, right? They had some misdemeanors, they had some things, but ultimately at the end of the day, what we found was that they've all been impacted by some traumatic event that had something to do with gun violence. One young lady showed up every week angry. We had tried other techniques, Reflect, Honor, Connect. When we were in small groups, when she would share, we had tried some other things, and it just really wasn't working as well as we would have hoped. What we saw was the anger that surfaced. And so one of the interns that was working with her was very, very helpful. She pulled the anger onion out. And with me sitting there, we began to just kind of have a conversation with her about what her anger was. And she got to writing, and what we noticed is that all of her anger has something to do with fear. So we know that with the anger onion that you have anger, then you have sadness, and then you had fear. And what we learned is that her sadness came from, she had been through multiple programs, right? She had been through lots of intervention programs because she had lots of trauma and lots of services and lots of therapy. And she felt as if this was one of the better ones, but had no hope. So she was sad that this would be another program. And ultimately her sadness then caused some fear. And the fear was that this is just like everything else, and it's going to end, and I'm not going to have the tools or the people that continually show up in these programs as someone that I can rely on, right? They come, they do what they need to do, and then they leave. And so we saw a lot of sadness. And that was really good for us to hear. And it was really good for us to identify with her, having her write it down, then having her talk about all the programs that she had been in. And so I believe that what was helpful was us showing her what the anger onion looked like, right? Like we just took it out and began to work with her through the concept so that she can identify exactly what the anger was coming from. And I do think that sometimes when we are doing some of the techniques, it's important to educate, because our clients are people that we work with, they don't necessarily understand why they are angry, right? But when she listed the reasons why she felt so angry, we were able to have a conversation with her about the sadness, and then address some of the fears that we could be different, right? If she gave us an opportunity, and really brought back in to reflect on her and connect things. But we were able to get to the fear to say, hey, what would be helpful for you? How would you like to see us show up in your life? And I really do think that that made the difference in us being able to provide an intervention and a mentoring for her, because what she was saying is that she needed connection. So I hope that you guys are able to use the anger onion in some kind of way in your organizations as well. And hopefully you can get the same results that we have here.
So it's notable that Mary Beccaria notes that you want to create a space of felt safety. Physical safety is one thing. Felt safety or psychological safety is another. And we'll come back to that in some of these other interventions that we have. So another one that I like to use, again, with a visual representation, it's called the person in the mandala. It was noted that the person should have clothes, because if they don't, it could trigger folks that have a history of physical or sexual abuse. So that's why most representations are drawn this way. So borderline is a diagnosis that involves a lot of strong emotions, usually anger. And again, anger is a secondary emotion. It's usually covering up sadness or fear, particularly about abandonment. So when someone has a strong emotion, to begin this process, we ask them to notice where in their body that they feel the emotion. Particularly for folks that have had a lot of history or abuse or substance use, they've tried to disconnect themselves from their body. So we want to help increase that mindfulness by bringing them back into their body and asking them to describe where they feel that physically. Whichever emotion it is, we want to ask them to give it a size, a shape, and a color. And then that's what that feeling is referred to: the big black star feeling, the green heart feeling, the little orange circle feeling. And you discuss what types of activities, places, or people trigger that particular feeling with that size, shape, and color. And we discuss whether or not a feeling is helpful or unhelpful. And then we work with the client to focus on people, activities, or environments that create or cause them to feel more of the helpful feelings and less of the unhelpful emotions. We want to minimize the interactions or environments that lead to the big unhelpful emotions. This can be used with both kids and adults. And for adults, there is a grid that goes along with this, which is part of the handouts that are going to be sent out. And it allows the client to organize each of these components. And that way it allows for more targeted focus on certain feelings.
Okay. So I'm going to talk briefly about psychodrama. I'm going to go pretty quickly through this because we're running a little short on time and I want us to get to our breakout room. Psychodrama is a group therapy modality. It is something that requires specialized training and certification, but if it's something you're interested in, you can definitely seek that out. It involves a client dramatizing a personal problem in a group setting. The client chooses what they want to act out. This can be specific events that have happened in the past, unfinished situations, or maybe a situation that they're preparing to face in the near future. It involves techniques like role reversal, where the client and another group member exchange roles and kind of act out a situation they've been in as somebody else. The mirror, in which the client becomes the observer while the group acts out the event. The soliloquy, which is essentially the client giving a monologue. The client shares their thoughts and feelings with the group. And the double, in which a group member acts out the client's emotions and behaviors. And then afterwards, the group member shares what they think the client is thinking and feeling in that moment. So there are 3 phases to psychodrama. The warm-up, in which everybody introduces themselves, rapport is established, they talk about the scene that they'll be acting out. The action, in which the client chooses a scene and then they do the actual acting out using the role reversal, mirror, soliloquy, etc. And then afterwards, the sharing phase, where the client describes what that experience was like for them, and the whole group discusses and kind of helps to process what came up. So I do have just like a super duper quick video about psychodrama. It's only about 2 or 3 minutes.
Psychodrama is no clue.
Something theatrical, something psychological.
That sounds interesting. Word, that's me.
That is absolutely not for me.
I'm psycho and I'm drama.
Psychodrama! I'm Nan Nellie Seif. I'm co-director of the Psychodrama Training Institute, which is part of the Sociometric Institute in New York City. Psychodrama is a creative arts modality. It really works on the basis of creativity and spontaneity.
My name is Jacob Giasciani, and I'm the co-director of the Psychodrama Training Institute. To begin with, we need to recognize the simple and real fact that we learn through action and interaction with people.
When I come to psychodrama, I have an opportunity to connect with others.
Going to group was actually the place that jump-started me to growing. I played a shrimp on the Barbie. I've been mothers, sisters, and madam.
One of my favorites was playing a cat.
Today I was auxiliary for God, and it was fun to be the God.
Whatever we do is done in action. We don't talk about problems in the abstract. We enact scenes related to them. It gives many opportunities to express ourselves more fully, to rehearse roles that are not well developed, to let go of roles that we don't need and they don't serve us anymore, and altogether deepen connections to other people.
The first part of a psychodrama group is the warm-up. We're getting to know each other and share and bringing up issues. After the warm-up, we go into the enactment, the psychodrama, on which a protagonist is chosen, and that person chooses other people to play roles in his or her drama. In that, we do things called role reversal, where the auxiliaries are trained to play the role by the protagonist. We can do scenes from the past. We can do it in the present. It could be a job situation, or it could be something in the future, something we want to go toward. If we're doing it with people playing different roles in our lives, we can get a different insight or their perspective of what's going on. It also can give us what we sometimes call an action insight, like all of a sudden in a drama we're talking to someone or part of ourselves and something says, oh my gosh, I got it. There can be anger, frustration, sadness and tears, openness, where a person is really sharing their heart with someone that they've had a hard time talking to. Then we come to the part of the sharing. Those people that played roles for the protagonist have a wealth of information. They start out by saying, in the role, I felt this and this. And this is really a key part that's different than some group therapies.
Are you okay?
Because we don't criticize or suggest. The protagonist has been on the stage and been very open.
No.
So in the sharing part of the situation, individual group members share what came up for them, share their identification. It really reconnects the protagonist and also gives them a chance to express what's going on and what was brought up. It really can be life-changing. It really can help you make those shifts you want.
Psychodrama has been one of the most powerful experiences of my life. It has given me a way of accessing, looking at myself in connection with the world out there.
I learned how to own my stuff and do it differently.
Processing of everything that a person could want to process.
You're allowed to change.
Primarily, it's about a dialogue of parts.
To have a lot more authenticity, a lot more honesty, a lot more presence.
We learn in action and that we can heal in action.
And this is what psychodrama does.
That was just a very brief kind of intro into what psychodrama is. Here's some other interventions that have been found to be effective for BPD. We unfortunately don't have time to go through these one by one. If you do want more information about these, though, I really encourage you to seek out more information about them. Steps in particular, systems training for emotional predictability and problem solving, was developed specifically for BPD and has been shown to be kind of a promising area. So that one in particular, I would kind of encourage you to look up more information about it. Acceptance and commitment therapy as well as showing to be promising for BPD. The one I will touch on is medication management. So medication management is not necessarily the best option for BPD. It can be effective for certain symptoms, but it's generally ineffective for the treatment of BPD and other personality disorders. There are no medication treatments specific to individuals with BPD that are approved by the FDA, but there are medications that can help address specific symptoms. Behavioral techniques have been found to be the most effective, and a combination of medication and therapy is commonly used. So for things like emotion dysregulations, antidepressants, SSRIs can be prescribed, although there's no specific medication that's recommended. SSRIs and mood stabilizers can be used for impulsive aggression. Antipsychotic medications might be prescribed to some individuals with BPD to help with severe dissociative symptoms if they're dealing with those. But again, this is not generally going to be the first line option for people with BPD. So with that, we're going to get to our breakout room here. So this will be provided as a handout with it all typed out. We will read it now as a group. And as we go through this, think about what kind of intervention you might choose when working with this individual. So Albert is a 33-year-old single Caucasian male who reports experiencing pervasively depressed mood following the dissolution of a 6-month romantic relationship. Albert describes feeling overwhelmed with feelings of emptiness and is convinced that he will be alone forever. He additionally reports being in and out of psychosocial treatments for suicidal thoughts, though denies ever having made any suicide attempts. He also denies engagement in non-suicidal self-injurious behaviors. Albert reports chronic difficulty managing his strong emotions and recognizes that others would describe him as moody. He further recognizes that he can quickly escalate with inappropriate and/or intense anger over minor transgressions, which subsequently results in feelings of guilt and embarrassment. His anger makes it difficult to sustain both platonic and romantic relationships. To cope, Albert frequently seeks reassurance from others, looking like calling in desperation to make sure they still care about him, and drinks excessively, meaning 6 or more drinks per sitting. Due to the heaviness and frequency of his drinking in the recent weeks, Albert has called out sick a few times from work to recover from drinking the night before. Albert has been diagnosed with borderline personality disorder and alcohol use disorder. Albert is looking for a treatment that will help him manage and regulate his intense emotions in an adaptive manner. In addition, he hopes to learn strategies to better navigate interpersonal relationships, meaning effective communication. Which therapeutic interventions would you use? So this is going to be shared as a handout. Kim just put it in the chat there. So you do have to download that before you are sent off into your breakout rooms. And when we come back from the breakout rooms, Kana is going to lead us in a group discussion. But in your breakout rooms, it would probably be a good idea to identify one person that is going to speak on your behalf to the group.
Yes, so I'll give you a minute or so to download that. You should see it in the chat called Albert case study and questions. Lydia and Kana, do you still want to do about 4 to 5 people in a room for about 10 minutes or so?
Yeah, how many people do we have right now?
We've got like 43-ish.
Okay.
So about 4 to 5 people per room.
Yeah, that sounds good.
Okay, for about 10 minutes. Oh, okay. All right, so please, if you haven't already downloaded that, take one last second, go ahead and do that, and we'll go ahead and send you guys to your breakout room.
If I close this little window that talks about breakout rooms, is it gonna like close the breakout rooms?
I don't think so. I think I'm managing them.
Okay, yeah, I got the little pop-up for it. I don't know.
Yeah, it says you can join whichever one you want. So.
Okay, let me actually stop recording too, or pause. Okay. All right, so I think everybody should be back now.
Okay. So for your designated spokespeople, what interventions did you choose? Why did you choose them? Did you identify any barriers to Albert being able to utilize any of the interventions?
I'll go first to kind of get my group kind of out of the way. We went with dialectical behavioral therapy, probably, for being honest, like more so out of comfort, because that's the one that we had like most familiar with even prior to training, to be able to speak more competently-ish on, because it includes like the interpersonal skills, it has tools for it, and it has the like distress tolerance stuff. But like the barrier that we identified was his drinking, and kind of figuring out where he's at with his drinking, and is he going to be all vulnerable, feeling vulnerable and exposed in session and then leave and go drink more. So kind of figuring out where the priority is as far as getting that drinking under control with possibly SUD treatment, versus doing DBT, kind of figuring out what that hierarchy looks like.
Address the addiction first before tackling mental health. Okay. Next.
I can go next. We were in group 4. I had Mary and Taylor with me, and we said the same. So DBT. We also, due to like just him kind of focusing on like interpersonal skills, since like in the vignette, he's able to describe, some of the aspects, like he's recognizing what he's finds like that he's struggling with. We had also said like CBT, even though it wasn't listed, because again, with like that interpersonal skills, he's recognizing that he's angry. So maybe he can learn some skills to be able to better manage some of that anger. We talked about the onion and like the empty chair technique, to give him an opportunity to say what he needs to say, with the dissolve of that relationship. We agreed, like the first group that went did, alcohol use is a concern, that's probably going to be a barrier for him. And also even maybe some acceptance. And we also had a conversation of like, what would you treat first, the alcohol or the BPD? And we've had a conversation of how they can each like be playing off of each other and doing that. So it's like, which one do you do first? I don't know that we found like a solid answer for that. I think that would be a work in progress, but it was a conversation we had.
Yeah, I mean, if they can say, is it the interpersonal stuff or is it the drinking, which do they want to address first? But I know ethically, at least for us as clinicians, if someone is intoxicated, we can't, do a session with them. We can't do an assessment with them. I think it would make it harder for them to remember the skills that they're trying to learn if they're intoxicated. So yeah, it could go either way depending on how serious his alcohol use is. Anybody else?
I can go next. I don't know what group number I was in, but I was with Jen, Merrick, and Robin Heminger. So we felt that that diagnosis-wise, we diagnosed him with borderline personality disorder. We felt that he could use a psychotropic medication assessment, so maybe a mood stabilizer. We did recommend also that he get a drug and alcohol assessment to really see what's going on with that piece, and then do DBT and individual counseling. And then we also brought up his attendance and kind of motivation piece in regards to him kind of dropping in and out of therapy.
We only know what people report to us. So he could say he's only drinking, but who knows?
Yeah.
Might be using some other things. Yeah. All right. Anybody else?
All right, I'll go. Now I don't know which group number I was in. And I think one of them may have to kind of help me out here. We had some issues kind of getting the case study downloaded and fine, so we had a little navigation. We decided on DBT. Oh gosh, ladies, help me out when I lost my rationale. Who else was with me?
I'll help you out, Stacy. You're welcome. We talked about DBT and our rationale being because of looking to find adaptive skills. So DBT is all about, was it effective, right? So we thought that would be good. And then let me pull this up real quick. Barriers, we talked about potential cognitive issues. There is, though, an adolescent DBT approach. So maybe using like a kid-friendly version might help with that barrier. We also talked about substance use as a barrier because of attendance, because DBT is also really good for substance use. So wouldn't necessarily have to go someplace else depending on, right, if he needs like how heavy he's drinking and if there was any like MAT programming or detox kind of stuff that might be a concern for that. Did I get all of those? I think so. Sorry, Stacy. I said I would help you and I just took over.
No, I appreciate you. Thank you. No, you nailed it. Awesome.
Anybody else before we move on? You can also feel free to pop some responses in the chat as well.
Our group had the exact same response as everyone else, basically, DBT and to do an assessment, or not an assessment, but maybe add antidepressants or something like that. So that was it.
You might have to stop drinking first, because a lot of psych meds and alcohol do not mix. So.
Right. But we also discussed too, like barriers would be if they're willing to participate. So that's it.
I can go next. I don't remember what group number we were. I want to say it was 6, but I have no idea. But anyway, we thought the best one was DBT. because it consists of those 4 modules, the emotional regulation, interpersonal mindfulness, all of that, which would address most of the symptoms there. But what's interesting though is it didn't say that he had a history of drinking. It said that he was drinking when he got, because a result of the breakup with a girl. So a lot of people with personality B disorders, they kind of go off the deep end when it's an environmental thing, but he might not necessarily be an alcoholic. He might be having like just, kind of like high risk self harm kind of behaviors.
Binge drinker
So
than a
yeah. So the only barrier really would be, obviously, he can't show up drunk to therapy. Um, and it would be really difficult for him to regulate his emotions to be stable enough, especially like, if it says that he's called off work a few times because he was sick. An alcoholic is usually they can function. If they've been at it for a while, they know when to get drunk and when not, and know how to,
how to
kind of play
manage.
the game. Yeah.
Gotcha.
No, that's
Yeah.
about it.
Yeah, I chose this one because it was a male identified person with a co-occurring substance abuse disorder that had been diagnosed with borderline, which is pretty rare to see as well.
Yeah, so it's more acceptable to drink and get mad than it is to cry and all of that and throw things or whatever.
Cut your wrists and things like that. Yeah. All right. Well, we got about 10 more slides to get through. So if anybody else wants to put their responses in the chat, go ahead. We're going to move on.
Okay. So thanks everybody for contributing there. I appreciate it. So the last little chunk of our training here is challenges of working with people with BPD. And we're going to go through each of these. So starting with stigma, you've kind of heard us kind of touch on stigma with this. BPD is one of the most misunderstood and misdiagnosed conditions. People with BPD are viewed as being dangerous, being manipulative, being unstable. A 2013 study actually found that behavioral health professionals have more stigmatizing views about treating BPD than any other diagnosis, leading many people to think that people with BPD or clients with BPD are attention-seeking, dramatic, manipulative, which can lead to worse outcomes in quality of care. So this is a big one when working with people with BPD, is just really unpacking that stigma and that unconscious bias. Some other considerations, scope of practice is a big one. Working with people with BPD often requires more advanced training, more experience. So it's important to kind of stay within your scope of practice, and supervision and consultation is important. Not all counselors are going to have the opportunity to work with a DBT team, but it's important to at least receive regular supervision and have that consultation when working with clients with BPD. Some therapy interfering behaviors. These are any behavior that create a barrier to the client's treatment and recovery. We've kind of lumped them into 3 categories. These are also, I should say, typically ongoing patterns, not an isolated event. It's not, somebody having a bad day one day and it's behavior, but this should be an ongoing thing. And they might be intentional or unintentional. So barriers to being attentive, just things like missing sessions, canceling last minute, being late or showing up intoxicated. Barriers to being collaborative, so being evasive with answering questions, yelling at the counselor, being overly critical of the counselor, or just withdrawing from the session and shutting down. And barriers to being adherent is just things like threatening to quit therapy, not doing homework, etc. Just not participating in the session. Okay. And then one of these behaviors is triangulation, which Kana, you were going to talk about.
Not that it's a nice thing to have a fun maladaptive behavior, but I like this one just because it's having fun. So Triangulation, we can also call that proxy recruitment. It's basically how to control or abuse another person by manipulating other people in the environment to backing the abuser and basically doing the dirty work for them. So colloquially, I've heard it called flying monkeys, like from The Wizard of Oz. The Wicked Witch, she's got the flying monkeys to go in and do her bidding. So again, with the imagery, to use a visual representation of this. And it's any person recruited to assist them in controlling someone else. This tends to happen a lot as contact decreases with another person. So if you think of Albert in his breakup, he might try to recruit other people to contact his former partner if they have completely gone no contact with him. They will go to friends, family, coworkers, almost anybody can be drawn in unwittingly into this type of power struggle. It's a form of gaslighting, essentially, because it's a way of establishing control over other people by forcing them into a defensive posture. They have to justify or deny false claims to all of these people in their lives, including those that are closest to them. It reverses the role and deflects attention away and provides cover for further abuse to continue.
Then splitting and regression are two other behaviors you might see. Splitting is a result of all or nothing thinking. And it essentially refers to either the individual is overvaluing the relationship or they're fully unvaluing the relationship. So as a counselor, that might feel like the therapeutic relationship is very valuable to the client. It means a lot to them one session, and then the next session, completely the opposite. This often happens when the client is having feelings of abandonment. It's kind of a self-protecting thing to do. You might also see regression when the client feels that they've made a lot of progress, but they are afraid of termination of therapy. So kind of getting back to that fear of abandonment. So they're afraid that if they accomplish their goals, they're not going to have their therapist as a support, which triggers that fear of abandonment. Okay, and then Kana was going to talk about transference and countertransference and some tips to work with those. You're muted.
In working with folks that have more serious mental health issues, being aware of what transference and countertransference is important so that we can recognize what's happening and be able to deal with it appropriately. So transference is when a client has an emotional response to us during their session. There's something triggering about us or what we're discussing at the time. And let's go ahead and move on to the next one too. And countertransference is when a client is causing a emotional response in us as the clinician. So when we have those responses, we might feel guilt, shame, or anger at times due to the demands the client places on us because they are high need, or sometimes just due to the slow pace of the client's progression through therapy. So self-awareness is pretty much key to being able to manage this really well. We have to recognize when our own core wounds and traumas may have been triggered by a particular client. Sometimes that may mean that we need to transfer them to another provider if it's something that is not able to be managed. If we're burnt out or we feel helpless or ineffective, that can impact our vulnerability to transference and countertransference. Working to not personalize a client's setbacks or take them personally, thinking that we're ineffective. our own areas of competence. We should stay in our own lane. Again, maybe a client will try to recruit us as part of a legal battle that they're having with an ex-partner over their children, staying out of environments and situations that are outside of our scope of practice. We need to have good boundaries and limits for the client, which we'll talk a little bit about next. And having our own therapy and our own supervision to make sure that we're taking care of ourselves at work and outside of work.
On the topic of boundaries, boundaries should be clearly communicated from the outset. First session, talking about boundaries, and they should be consistently enforced. We need to really stick to them. We can't be wishy-washy. They have to be clearly communicated. They have to be reasonable. They have to be consistently stuck to. Part of this might be consistent session times, consistent session durations, are clearly communicating what modes of communication are acceptable in this therapeutic relationship. Is it okay for them to call you in between sessions? Is it okay to send emails? Is it okay to text? Set boundaries on that early, and then set reasonable expectations for your response times. So they shouldn't be expecting you to respond instantly. Avoid dual relationships. As we kind of mentioned on the last slide, or with countertransference, be aware of your own emotional responses. We're human, we're going to have emotional responses. We need to be aware of those and know how to work with those. Avoid self-disclosure, stay out of power struggles, and model these healthy boundaries, because healthy boundaries in the therapeutic relationship should kind of serve as a model for healthy boundaries in any sort of relationship. So termination, we do have a handout about discharge planning that can be sent out afterwards, but in short, clients should understand early that therapy is going to end at some point. Termination, this conversation should start at the first session. You should explain early that it will eventually terminate. So reasons that it could end include that the counselor is kind of out of their scope working with this client. They don't have the competencies to meet these goals. Maybe the client needs a higher level of care than what we offer. Maybe they've reached their therapeutic goals and they just don't need a therapist anymore. Obviously, if the client has been threatening the counselor doesn't feel safe, or some kind of situation comes up that impacts the counselor's judgment or objectivity, like a dual relationship emerging. So to start the conversation about termination could include questions like, how are we going to know when our time together is coming to an end? How will you know that you've made progress toward your goals? What does success in treatment look like for you? And again, this is an opportunity to model healthy boundaries. Okay, and then we're just finishing up here with some do's and don'ts. So do's for working with BPD: do be clear with those boundaries, establish them at the beginning, stick to them throughout, be consistent and reliable, do what you say you're going to do. Validate emotional experiences. So you can acknowledge the emotions and validate those emotions without necessarily agreeing with their interpretations or their behaviors associated with those emotions. Use evidence-based modalities, such as some of those we've covered in this training. Encourage and reinforce use of skills. So if a client is using these healthy coping skills that you've been working on, provide praise for that when appropriate. Model emotional regulation yourself. So be calm, be non-reactive, even during intense sessions. Engage in regular supervision and consultation yourself. BPD can be emotionally taxing to work with, but having your own support, your own people that you can go to, helps maintain objectivity and prevents burnout. And promote client autonomy. Help them build confidence in their own problem-solving skills, their own decision-making abilities. And for our don'ts, don't take things personally. As Kana said, don't personalize their outcomes. Emotional outbursts, idealization, devaluation are symptoms. They're not reflections of your value as a therapist. Don't be inconsistent. Like I said on the last slide, be consistent. That inconsistency can trigger fears of abandonment and kind of reinforce those patterns that they found themselves stuck in. Don't rescue or over accommodate the client. That can reinforce dependency and helplessness. It also kind of weakens boundaries over time. Don't dismiss or ignore emotional intensity. This can invalidate and worsen the emotional experience. Don't assume that they're acting manipulatively, especially with like self-injurious behavior, suicidal ideation. Don't assume that they're just saying things to say them. They're trying to express difficult emotions, and that should be taken seriously. Stay out of power struggles. Don't engage in power struggles. Stay collaborative and respectful, even if you're setting limits or addressing transference issues. Again, don't allow boundary violations, and don't work in isolation. Collaboration with the client's treatment team, your supervisor, the client's family when appropriate, and any other supports is crucial. And that's all we've got for you today. We do have just a little moment here for any Q&A. Kana, did you want to add something here or no?
Not in particular. If anybody's interested in the ways to get the DBT for PTSD workbooks, I can look up that information and make sure it goes out with the handouts as well.
Okay. Well, awesome. Thank you guys.
So thank you so much, Lydia. Thank you so much, Kana. We are just a little bit over time, so I want to be respectful of people's time. If you'd like to hang around for questions and answers, maybe we can be here for a few more minutes. Otherwise, I understand people may have to go. Like I said earlier, I will send after this training is over the evaluation. A lot of the handouts and resources that were referenced throughout the training today will be attached to that. Please return the evaluation to me within 5 business days, and then I have 5 business days and to get you your certificate of attendance. If you have any questions about that or that process, please reach out to me and let me know, and I'll answer your questions. Otherwise, thank you guys so much for coming. I hope it was informative and gave you some good information, and we'll hang out here for a few minutes for any Q&As that you may have for Lydia and Kana. So thank you guys. Have a good weekend.
Thank you.